Okay, we can start the program. Hello, everyone. Welcome to the second session of TUMS Board Review in Hematology and Oncology online short courses. I am Dr. Marjan Yaghmai, Associate Professor of Medical Genetics at Oncology, Hematology, and Cell Therapy Research Institute at Shariati Hospital, Tehran University of Medical Sciences, TUMS. And I am head of the Leading House of Iran and North America Academic Partnership at TUMS. This course, planned by the Leading House of Iran North America Academic Partnership at TUMS in collaboration with Oncology, Hematology, and Cell Therapy Research Institute and Kermanshah University of Medical Sciences. We intend to provide our hematologists and oncologists with an opportunity to access the latest update of cell therapy and stem cell transplantation. We hope these interviews can lead to a better understanding of our patients' treatment. I need to take a moment here and express my gratitude to Professor Mark Stewart, our invited speaker from the US, for his kind support and collaboration. If you wish to receive an international certificate of attendance for each session, you need to register by Appraise to Raise website that the link can be found at the chat box. Today's session is entitled Hematopoietic Stem Cell Transplantation. I would like to introduce our moderator, Dr. Amir Abbas Rashidi, Assistant Professor of Hematology and Oncology at Kermanshah University and Medical Sciences. Please feel free to ask your question in the chat box. Thank you all again for participation in our course. Please make sure to write your correct name, the one that you have registered with, and please try to keep the chat in English. I sincerely hope that you have an enjoyable academic experience today. Now let me welcome Professor Mark Stewart to the stage and ask Dr. Amir Abbas Rashidi to introduce our speaker. Amir Abbas, please.
Thank you, Dr. Yaghmai. Ladies and gentlemen from around the globe, greetings to all. My name is Amir Abbas Rashidi. I serve as a moderator for today's webinar. I'm medical oncologist and hematologist, faculty member of Kermanshah University of Medical Sciences. It's an immense privilege to connect with such an esteemed audience today. Before we delve deeper into our topic, I'd like to extend my sincerest gratitude to Dr. Yaghmai and her leadership and contributions in House for Iran North America Academic Partnerships have been pivotal in making these webinars possible, and we are indeed fortunate to have her expertise and guidance. Now, I have the distinct honor of introducing our esteemed speaker for this session, Professor Mark Stewart. He currently serves as the Vice Chair of Department of Hematology and Hematopoietic Cell Transplantation and is a clinical professor at the same department. As a seasoned hematologist and oncologist, Dr. Stewart has a remarkable 40 years of experience in the field. He previously led the medical director of Seattle Cancer Care Alliance at the Fred Hutchinson Cancer Center for 20 years and has led leadership roles at the University of Massachusetts and University of Virginia. Dr. Stewart's research focuses on engraftment biology, cellular immunotherapy, drug safety, and health skill delivery. We are privileged to have him with us today. Dr. Stewart, please.
Oh, thank you very much. Very kind interview. Appreciate that. Looking forward to our session today and hopefully all of your questions. So let me go ahead and start. We always disclose a few things here. Those are my disclosures, not too many. What I'll try to do is not read every slide, but rather take the highlighted parts of the slide. Also have a number of slides if you're going to get copies of the slide deck that can be supplemental pieces of information for the talk that you might find of interest. So I wanted to highlight a recent publication, a recent book by my former boss, Dr. Fred Applebaum. He was one of the fellows of Don Thomas who won the Nobel Prize, and he's written a book about Don Thomas. Don Thomas, back in 1990, won the Nobel Prize for stem cell transplantation in Seattle. And this book is kind of a history of Don's work, but also a history of stem cell transplantation. It's written very well, and if you have an opportunity to acquire this book, it's quite interesting. So, would commend that one to your as a recommendation. So let's go ahead and start. To begin with, Dr. Thomas, of course, was able to pioneer bone marrow transplantation back beginning in the early 70s, and ultimately began doing transplants in the late 70s and early 80s. And of course, much of this was based on the idea that one could ablate with radiation bone marrows in animals. And if the spleen, for example, were shielded from that radiation, remarkably, back then, the bone marrow would recover, which suggested that there were stem cells in the spleen that could repopulate. Based on that, Dr. Thomas applied total body radiation to many leukemia patients and extracted bone marrow from their relatives and infused it. And in the early days, there were tremendous numbers of patients who either rejected the bone marrow or developed severe graft versus host disease. And it wasn't until HLA typing was developed that we began to see much better takes and less graft versus host disease. And so in about 1980, the reporting started for bone marrow transplantation. And initially it was mostly allogeneic transplants, the blue line there. And you can see that gradually the number of allogeneic transplants increased, but then actually it was Dr. Applebaum at the NCI who performed the first autologous transplant for patients with lymphoma. And that was published back in the mid-80s. And with that, the number of autologous transplants increased pretty dramatically because it was easy to get a donor. Allogeneic transplant was compromised to some extent because donors weren't as readily available. But for lymphoma, there were patients who could, of course, had clean bone marrow by microscopic examination and could undergo autologous transplantation. Now you see there's a big drop here in the number of autologous transplants, and that was back around 1999 or so. In addition to lymphoma and ultimately myeloma, back in the late 80s and 90s, breast cancer was one of the diseases that was where autologous transplantation was used. But in about 1999, there were several papers that did a randomized study in breast cancer for both high-risk local disease and metastatic disease, and this showed improved survival. These were studies that were done from South Africa and Johannesburg by Dr. Bezwoda. And I was one of the auditors who went to Johannesburg to kind of validate that these results were true and that we could move on and consider transplant a standard of care in breast cancer. When we went to South Africa, we found that there was actually not the data that was published. There were charts that were missing. Most of the control charts were missing. And finally, Dr. Bezwoda admitted that this was a two contrived studies. And we published this audit in the Lancet, and immediately thereafter, people basically said, well, we haven't we don't have evidence that this works in breast cancer. So you see the big drop there. But gradually, of course, we were able to show that this was helpful in diseases like myeloma and lymphoma, and the number of autologous transplants then began to increase. So let's see if we can get, there we go. So here you look at the number of autologous versus allogeneic transplants in the different disease categories. It's pretty unusual nowadays that we do allogeneic transplants for myeloma. These are mostly confined to the leukemias and aplastic anemia, whereas autologous transplantation is largely used in myeloma, non-Hodgkin's lymphoma, Hodgkin's disease, occasionally other malignancies like neuroblastoma or germ cell cancer, and so forth. So here you see the different types of allogeneic transplant. So we have matched unrelated donor transplants, we have haploidentical transplants, mismatched unrelated donor transplants, and cord blood transplants. So with the establishment of marrow donor banks where people volunteer to be a donor, the number of matched unrelated donor transplants that you see over here eventually exceeded the sibling donor transplants. And of course, the matched related donor transplants were preferred in the beginning. The donors, of course, were available because they were relatives and they freely, of course, volunteered to donate. But it wasn't until large numbers of patients, of donors, I should say, were enrolled in the registries that one began to use the matched unrelated donor transplants, and those now are the most common form of allogeneic transplants. Now, the number of matched related donor transplants has kind of tapered off a bit, probably for a variety of reasons, but what we've seen is the ascendancy of haploidentical transplants. Now, most of you know probably that a haploidentical transplant is like a half match. So instead of a fully matched sibling donor, we would use one that was matched at only one chromosome number 6, that is half matched. So half of the antigens are matched and half are unmatched. And one might say, well, how can that be? How can you do that? The risk of graft versus host disease or rejection is so high that seems impossible. And the way that that's done is we give what's called post-transplant Cytoxan in high doses, which seems to equalize the tendency to graft reject and the tendency to develop graft versus host disease. So haploidentical transplants, which was pioneered largely at Johns Hopkins University for many years, has now taken hold and many people are able to use this modality. It has the advantage in that it probably has a lot less chronic graft versus host disease, which is an important quality measure. So becoming much more popular. You can see the other modalities here, the mismatched unrelated donor and the cord blood. Cord blood has actually fallen out of favor now in a prospective trial that looked at haploidentical transplants versus cord blood. We'll talk about that in a moment. So here you can see the other differences, that is, how often do you use bone marrow versus peripheral blood as a source of stem cells? And here you can see that peripheral blood pretty much dominates the field here in terms of a source of stem cells. Here you can look at the age of patients. So more and more we're transplanting older and older patients. And you can see that a substantial number of patients who are age 65 or greater are now being transplanted in the year 2021. And these, by the way, are the latest CIBMTR slides that show an update in these data. And largely we've been able to do this because we've been able to control graft versus host disease, and we've been able to control the intensity of the chemotherapy that we give. We'll talk in a moment about how the intensity of chemotherapy may relate to the degree of cytokine storm that is created. That is, higher doses of conditioning chemotherapy create a much stronger cytokine storm. Lesser amounts of chemotherapy produce less cytokine storm. And when you infuse stem cells, they're stimulated less if you use a less ablative type of regimen, and therefore perhaps produce less severe graft versus host disease. So a few words about autologous stem cell transplantation. Of course, this requires, in all cases, ablative therapy. And we use, of course, self marrow that's collected and frozen and then thawed and infused after the conditioning regimen is given. And the downsides of autologous transplant are the potential risk of tumor contamination in the graft, since this is coming from the patient. And although we try to render the patient as tumor-free as we can in the marrow before collection, there of course still is a risk of tumor contamination. There have been lots of ways to try to address the tumor contamination problem, either with antibodies that select tumors and destroy them in the marrow before the marrow is infused, or the other approach has been to select out the stem cells. So one method is to collect CD34 stem cells in a column and let the other cells pass through the column, and then add reagents that release the stem cells from the column and collect those and infuse them, thinking that they are purified stem cells and have been rendered tumor-free. The downside for that is that you also lose the T cells, and the T cells, when lost, then make it easier for patients to develop viruses that you normally don't see in autologous transplantation, like CMV. We should note that the 100-day mortality should be less than 5%, because the supportive care that we give now is at an all-time best in terms of getting patients through the naders and the infections that ensue. But the other downside is that you don't have a graft versus tumor effect with autologous transplantation. So that is an advantage of allogeneic transplantation, and the final downside is in a small, tiny percent of patients, particularly those that get total body radiation with autologous transplant, there is the risk of developing secondary cancers such as MDS or AML. So these are the number of transplants that have been done in either myeloma or non-Hodgkin's lymphoma. And you can see most of these are multiple myeloma. It used to be said that double transplants in myeloma was a good thing and that it prolongs survival. But this was a study that looked at a comparison of double transplants versus single transplants, plus a particular maintenance regimen, plus single transplant and other maintenance regimens. You can see that whether you got a double or a single, it really didn't matter in terms of overall outcomes. This was a study that was published by a City of Hope investigator. Now, autologous transplantation has been used in other diseases, other rare applications of autologous transplant. One is multiple sclerosis. And these studies were published by Richard Burt from Northwestern University. And you can see here that patients who have multiple sclerosis, if they're in a particular risk category that you can see on the right side of the slide here, if they're given high-dose therapy and autologous transplant, if you compare that to regular treatment, that the time to progression or the time to first relapse of the multiple sclerosis is significantly reduced, as you can see in the two graphs on the left. It's been a little more difficult to convince neurologists that this might be an approach, because of course there's always a risk of morbidity and a tiny mortality rate. And so the neurology group have developed what they have attempted to do as a consensus of who might be the people who would benefit the best from this. And those would be younger people under the age of 50 who've had multiple sclerosis for 10 years or more, and that they've had relapsing multiple sclerosis in different forms despite treatment. Once you undergo transplant, the results actually seem to be sustained at a median of 6.2 years, which I think is pretty remarkable. The other rare application of autologous transplant is in severe scleroderma. This was published by Keith Sullivan in the New England Journal a number of years back, again showing that here overall survival was improved with autologous transplantation in scleroderma, as well as the event-free survival. So another application of autologous transplantation. So in autologous transplantation, peripheral blood stem cells are the main source. It is very rare to use bone marrow. When it's done, it's usually done as a backup. And we've gotten much better now at collecting stem cells, peripheral blood stem cells. The theory behind collecting peripheral blood stem cells is you give the patient at an appropriate time when the marrow is minimally contaminated, if not completely uncontaminated with tumor cells. You give GCSF to the patient, and that causes the stimulation of neutrophils to release metalloproteinases, which then affect that connection between the stem cell and the microenvironment in the bone marrow. And you can see the disruption there between CXCR4 and SDF1 that causes the release of stem cells into the blood where you can collect them. Now, in a number of cases, that the GCSF is not adequate to collect autologous stem cells. And there are now a number of drugs on the market that actually more directly affect this bond between the stem cells and the microenvironment and produce a much greater number of stem cells that are released into the blood. And so this is, I think, an advance. Plerixafor has been the drug that we've used for many years. It's quite expensive. But now that there are other drugs, we anticipate that the price is going to come down on Plerixafor, and we will probably use these drugs much more frequently. So talking about allogeneic transplants, the concept is kind of the same as autologous in the very beginning. That is, you give a patient ablative therapy and then infuse the stem cells, and then you have a period of neutropenia and toxicity, including mucositis, liver toxicity, various infections, and then there's recovery. And that's very similar to autologous transplantation. The difference, of course, is you're infusing allogeneic stem cells instead of autologous stem cells. And the allogeneic stem cells, of course, predispose to a host of other complications, such as graft versus host disease, unusual infections that normally doesn't occur in, or that normally don't occur in autologous transplantations, like CMV, persistent fungal infections, persistent bacterial infections, and so forth. So a much more complicated approach. Now, we can talk a little bit about survival after allogeneic transplant, and we'll take acute myeloid leukemia here as an example. And to illustrate what the difference is between a matched related donor and a matched unrelated donor, and these are in adults over the age of 18. And what you can see here is when they are transplanted, when these two groups of patients are transplanted in either first remission, second or greater remission, or relapse or never in complete remission, you can see now that matched unrelated donor transplants pretty much approximate matched related donor transplants. That is, we've gotten so good at matching unrelated donor patients that the outcomes are pretty close to the same, although most would still prefer a matched related donor over a matched unrelated donor. You can see here the survival after autologous versus allogeneic transplant for follicular lymphoma. The MD Anderson group and Sloan Kettering group have reported that there may be, with allogeneic transplant, perhaps a slightly better plateau in disease-free survival. And of course, the outcome is often related to whether you have chemo-sensitive disease or chemo-resistant disease. And that's a common theme throughout transplant. Chemo-sensitive patients do better than chemo-resistant patients. Here you can see after transplant after chronic lymphocytic leukemia. Again, these are the CIBMTR registry data. And you can see a little bit of a stratification here between matched related donor having slightly better outcomes than matched unrelated donor, haplo, or mismatched unrelated donor. Here you can see for severe aplastic anemia under the age of 18 versus greater than the age of 18. Again, a stratification based on the kind of donor that you see here. Matched related donor producing perhaps the best result again. So the characteristics of allogeneic transplant, a much higher 100-day non-relapse mortality rate. We said autologous was less than 5%. This is 10 to up to 30% or sometimes higher depending upon the risk category. And what you need is immune suppression to allow donor engraftment. We'll talk more about that in a moment. The advantages here are that you have a clean, normal stem cell source, and that you have the additional benefit of a graft versus host or graft versus tumor effect. The downside being, of course, graft versus host disease, which is an attack of the new immune system on normal tissues in the recipient, and that can cause significant morbidity and mortality. So the graft versus tumor effect is demonstrated by a lower relapse rate in an allogeneic donor compared to, for example, identical twin donors. And that you can induce occasionally remissions with donor lymphocyte infusions. So those are evidence that there is a graft versus tumor effect. Now, we talk sometimes about, and particularly in leukemia, about minimal residual disease. And if you have minimal residual disease, and this is defined in a variety of different ways, does that relate to what kind of conditioning regimen that you should pick? In other words, if you have no minimal residual disease, can you use a less ablative regimen? If you have minimal residual disease before the transplant, do you need to use more an intense regimen? So this is a study that was reported by Seattle, looking at minimal residual disease pre and post transplant. So if you are negative for minimal residual disease before you get your transplant, and the same thing after transplant, that was understandably and logically had the lowest risk of relapse and the highest overall survival. If you had minimal residual disease pre-transplant and post-transplant, or had it post-transplant, you had a poor survival, regardless of the conditioning regimen. But if you had minimal residual disease pre-transplant and you were able to render the patient disease-free, then the survival was intermediate. And minimal residual disease appeared to be cleared more commonly with a myeloablative regimen than with a less intense regimen. So that just gives you some window as to how to maybe interpret minimal residual disease. Minimal residual disease is not easy to define, and it takes actually sometimes special tests to define that, special flow cytometry tests that most centers don't have at this point. The University of Washington does. Interestingly, City of Hope sends all of its minimal residual disease studies to the University of Washington, as do many other centers across the country. Now, the other rare application of allogeneic transplant is in sickle cell patients. This was a study of 204 patients who underwent allogeneic transplant. And remarkably, but maybe not surprisingly, 2/3 of the transplant recipients remain free of veno-occlusive crises over 2 years following transplant. And the downside, of course, is that these patients had to experience, in some cases, graft versus host disease. So the question is, are you trading one chronic disease for another if they get graft versus host disease? And there, of course, was a small but measurable mortality rate. So there have been other recent applications of cell-based therapies that are probably important to talk about. So we just talked about sickle cell transplants and allogeneic transplants, but there may be actually a better way to do this, still very much in a research mode. But this was the first study here that we're talking about in sickle cell patients is one that was reported in the New England Journal of Medicine about 1.5 years ago. And it was in 35 patients who received gene therapy for sickle cell anemia, a lentiglobulin gene infusion, and this replaced basically hemoglobin S with a modified hemoglobin A. And what happened was there was improvement in the profile for hemoglobin by electrophoresis. And in addition, 25 patients who were evaluable had a very significant reduction in the vaso-occlusive events, with a median going of 3.5 events per year to almost complete resolution. So this is a very promising therapy. People are estimating this may cost something like initially 2.5 million per patient. We don't yet at this point know how long this will be sustained, but basically requires treating the autologous marrow with this lentiglobulin ex vivo, giving the patient ablative therapy and then reinfusing these modified stem cells, but producing a pretty impressive effect. The other rare use of transplant is in patients who have a disease called Schimke immunoosseous dysplasia, which is an immunodeficiency disease that's associated with kidney failure. Patients need kidney transplants. And the question is, in this disease, this unique disease, could you use a haplotransplant with kidneys from the same donor? And would everything be tolerized? That is, the stem cell transplant plus the kidney from the same donor. And in this case, there was full engraftment, no graft versus host disease because they got a haplotransplant with post-transplant Cytoxan, and had basically a recovery with the kidney graft taking and no continued immunosuppression, which is pretty much unheard of. If you get a kidney transplant, you usually need long-term, lifelong immunosuppression. At least in this case, when the bone marrow was applied, you didn't need any. Finally, the third innovation in allogeneic transplants is to be able to use a very unique but rare donor for allogeneic transplant to cure, we think, HIV-1 infections. And this is a donor that uniquely has a protein on the surface of the cell, CCR5, which confers resistance to HIV infections. So there are now 2 or perhaps even more patients, maybe 3 or 4, who have received transplants from this super donor that has resistance to HIV infection, with basically the elimination of detectable HIV post-transplant. So I mentioned that there are a variety of different conditioning regimens, some very intense that we call ablative, some that we call reduced intensity, and others that we call non-myeloablative. All of them can result in the take of stem cells from donor to recipient. However, you use these different intensities, as I mentioned, depending upon, to some extent, the degree of disease that you have that you need to eliminate. I won't go through each of these, but you can read these in terms of what's defined in the categories. Now, if we look at the factors for selecting an allogeneic donor, these are the priorities that you can see here. So conventional practice would say an HLA-matched family member is the #1 donor, followed closely, as I mentioned before, by an HLA-matched unrelated donor. There's about a 60 to 70% chance of finding an 8 out of 8 match in Caucasian patients, and unfortunately, a lower degree of matching in other minority patients. As a consequence, people have looked for alternative donors, and haploidentical donors are really a very important now source of donors for allogeneic transplant. Cord blood donors have been used, and mismatched unrelated donors have been used also. The latter being a topic now of great research interest. So there are secondary factors for selecting donors. The most important one is the age of the donor. So the younger the donor, the lower the mortality rate, to the tune of 3% reduction in mortality for each decade that you lower the age of the donor. Here I've said the opposite, 3% mortality for each decade of increase in the age of the donor. And that's pretty significant. So as you look through registries and you have the options for donors, picking the youngest donor is likely to be the best. But of course, these are secondary to picking a good HLA match in the beginning. CMV status of the recipient and donor are another secondary factor. The preferred is if you have a CMV negative patient, getting a CMV negative donor and receiving CMV filtered or negative blood products will essentially almost guarantee you no CMV infection post-transplant. If you have a CMV positive patient, getting a CMV positive donor is probably preferred, but of course won't completely eliminate the risk of CMV. ABO red cell match is of interest, but we have ways that we can get around that when patients and donors are mismatched according to ABO mismatching. Now, one of the things over the last decade that's come to light is beyond the precision that we have for HLA typing, which is really quite good now at a molecular level, does it make a difference how antigens are expressed? So not that they're just matched, but they can be matched and have a high expression, or they can be matched and have a low expression. And does that make a difference? And here, if you look at, for example, HLA DP beta 1, you can see that in the case where there is a high expression of antigen, there is a much greater graft versus host response compared to a low expression. And these high expressions versus low expression characteristics are really genetically driven. So you can see there, those are molecularly detected difference that will predict high expression versus low expression antigen. And so that may be another factor that we look at when we try to select donors. If we want a higher expression to produce a higher graft versus leukemia effect, as an example, versus lower. Now, the other thing is that with experience and history, we've been able to identify T cell epitopes, that is, those genetic HLA characteristics that are associated with higher rates of immunogenicity, that is, higher rates of graft versus host disease. So we've cataloged these into groups, and so that's another way of looking at the propensity for developing graft versus host disease versus non-graft versus host disease. Now, if we begin to talk about to the patient, well, what are your risks based on your individual characteristics of surviving a transplant? There are a lot of comorbidity indices or indexes that have been looked at to predict. So there are comorbidity indices for diseases like heart failure, diabetes, and so forth that confer a risk of non-relapse mortality. There's also a disease risk index that have been published for the degree of disease as predicting outcome. And then there are ones that try to combine both. There's a great treatment-related mortality calculator at the Fred Hutch website that I've put there, where you can plug in your patient's characteristics and get some idea of what the comorbidity risk is for non-relapse mortality. So that's a good reference and probably should be done on every patient. Here you can look at and see that some of these comorbidity indices will predict outcome in transplant. I won't go through all of these, but based on the score, there is a difference in terms of overall survival and how you can predict that. Now, the other thing that we've looked at over the decades, particularly in Seattle when I was there, was how do transplant patients do over the last 2 or 3 decades? And so this is a study that was published in the New England Journal, and it looked at patients who were done in the 90s versus the early 2000s versus later 2000s, more recent 2000s. And these are all matched patients. So the comparison here, as best could be determined, were all matched with regard to a variety of different characteristics. And what you see is for the probability of death, the more recent category of patients, that is the 2013 to 2017, had a much lower risk of death compared to similar patients in previous decades. And why is that? Well, the hypothesis is that we have better HLA matching now, we have better supportive care, including antifungal and antiviral therapy. We have less aggressive conditioning regimens, such as targeted busulfan, as an example. And so those have been the major advances. And of course, this has been great for patients. So the allogeneic source of stem cells, like autologous, is peripheral blood stem cells in many of the cases. But of course, bone marrow has been used in haploidentical and aplastic anemia, less so now in both of those categories, particularly less so in haploidentical, where peripheral blood is used more frequently, unless there are other factors. And then, of course, alternative donors have been used. So umbilical cord transplant, again, is kind of fading out in many centers as an option, still used, but not as frequent because of the rise of haploidentical transplants. It had a number of advantages. It was easy to get because it didn't require harvesting any donor. You just had the cord blood at the time of the mother's delivery of the fetus. It was available for immediate use. That is, it was frozen, but available right off the shelf. It didn't have many of the infections that sometimes can occur with donors, like CMV. And it had, interestingly, a lower incidence of graft versus host disease, which meant that you could use mismatched cords to a higher degree. That increased the number of potentially eligible patients for cord blood donation. The limitations were there's more delayed engraftment, higher rates of graft failure. You often need to use 2 cord bloods in an adult patient. And the cord bloods transplants are about, in US dollars, about $70,000. Now, haploidentical transplants, on the other hand, have lots of advantages. Usually you can find these with either a parent or a child or a sibling as a potential donor. It has the ability to get a donor quicker than a matched unrelated donor through the registry. And of course, it's much cheaper than an umbilical cord blood. And you have the advantages of having additional source of stem cells in the future if you need them for booster types of cell therapies. The disadvantage is that you do require additional immune suppression because these are half-matched patients. And the most common way to do that is with post-transplant Cytoxan, which we'll talk about in a moment. So this was a study that was performed with Dr. Paul O'Donnell's involvement. He was at the Hutch. It was published in Blood in 2021, and this is a comparison of haploidentical transplants versus double cord blood transplants. And you can see that the haplos have an advantage here in terms of overall survival. This has shifted, of course, a lot of the treatment approaches away from cord blood and toward haploidentical transplants. So let's talk about graft versus host disease. I mentioned early on that when you give ablative therapy, there's a lot of tissue damage, and this results in the release of cytokines producing what we call cytokine storm. The incoming bone marrow cells or peripheral blood stem cells, particularly the T cells, are affected and stimulated to produce acute graft versus host disease. And so the theory is that the lower the intensity of the regimen, perhaps the less intense the cytokine storm is, and the less graft versus host disease intensity you have. And this has allowed us to do this in older patients using lower intensity therapy, since the patients are able to survive some of these graft versus host disease complications. Lots of things that impact the risk of graft versus host disease. I'm not going to go through all of these. Obviously, if you're HLA mismatched, that's a big factor for graft versus host disease. Sex mismatching, we talked about age of the donor, and so forth. In addition, for chronic graft versus host disease, peripheral blood stem cells has a greater risk of chronic graft versus host disease than bone marrow, although this is becoming less of an issue with the utilization of post-transplant Cytoxan, particularly in the haploidentical transplants, and maybe now in the fully matched, fully matched unrelated transplants. So this was a paper published in the New England Journal of Medicine, which does exactly what I just mentioned. It's looking at from patients who underwent transplant that were not haploidentical, but regular optimally HLA matched donors, looking at the use of post-transplant Cytoxan versus no post-transplant Cytoxan. And you see here that the incidence of acute GVH, chronic GVH, and relapse or progression or death was less in the patients who received post-transplant Cytoxan, and these were not haploidentical patients. The overall survival at this point is not really different yet, but suggests that this approach can be applied and may improve the quality of life of patients, even if they're not haploidentical, but rather fully matched. So post-transplant Cytoxan, you would think in high doses might impair engraftment, but in fact it spares stem cells. So giving this on day 3 or 4 post-transplant reduces graft versus host disease, particularly chronic graft versus host disease, and also permits engraftment. So again, spares the stem cells remarkably. So acute GVH is associated with skin rash, diarrhea, liver dysfunction, but most importantly, infections, since it's a sign that the new immune system is, you can think of it as confused. It's attacking the recipient's tissues and probably directing less specific immune therapy to infections. And therefore, even though you may have a normal white count post-transplant, if you have graft versus host disease, you're still at high risk for developing infections. The severity depends on a variety of factors that we've talked about. Steroids are still the first line of treatment, although we've been able to add Jakafi now. It's kind of a second line of treatment. And in people who are refractory to steroids, the mortality rate is predictably quite high. Here you can see the manifestations of skin, the most common manifestation of GVH. Looks like a drug rash. We often do skin biopsies, but usually these are only helpful after about 3 weeks post-transplant, since it's hard to distinguish between chemotherapy effects on the skin and GVH until after 3 weeks. And the skin involvement can vary from mild rashes all the way to developing epidermal necrosis and bullae looking like a severe burn. The second organ that's affected is the gut with GVH, and there are different syndromes here. Diarrhea is the most common, and typically the characteristic is that it's somewhat green and mucoid. In severe forms, it can cause intestinal bleeding and cramping. That's often grade 4 gut graft-versus-host disease. And it's important to make the diagnosis, since other things can cause diarrhea, like CMV enteritis or Clostridium difficile, other viruses. So doing endoscopy is very important. There is a syndrome that affects the upper tract, the stomach, with graft-versus-host disease that's not uncommon. And this usually happens maybe 3 weeks after transplant, when the patient has persistent nausea, sometimes vomiting. And these patients can have biopsy-proven graft-versus-host disease, but in the absence of other signs of graft-versus-host disease, respond to a short course of steroids and what we call topical steroids, steroids that are not absorbed into the gut. And these are compounds called beclomethasone and budesonide. Both are topical steroids for the gut, that is topical to the gut surface, and they may help in this case of a mild gut graft-versus-host disease. So this is what it looks like. It's hyperemic on endoscopy. And on biopsy, you can see exploding crypts here as one of the characteristics of graft-versus-host disease. If you look at small bowel analyses on CTs or small bowel follow-throughs, you can see small bowel thickening on the CTs. Again, the treatment is methylprednisolone for grade 3 and grade 4 graft-versus-host disease at 2 milligrams per kilogram. For grade 2, it's probably about 1 milligram per kilogram to start out with, and that for that upper GI tract syndrome, you can do a very short course of 1 milligram per kilogram plus those topical steroids that I mentioned. Jakafi or ruxolitinib is a good second-line treatment here with good response rates. People are thinking about using Jakafi up front with steroids, with or without steroids, but current approach is still steroids first and then Jakafi. Extracorporeal photopheresis is another modality for treating graft-versus-host disease, both acute and chronic. And the way this works is you give you add psoralen to an ex vivo collection of cells plus ultraviolet light, and the psoralen plus ultraviolet light causes inactivation of ex vivo lymphocytes. So you hook someone up to a pheresis machine, you pull off cells, you add psoralens, you expose them to ultraviolet light, that inactivates them, you put them back into the patient, and a percent of cells then are less active in terms of graft-versus-host disease, but not all cells, because there's always some cells that haven't been affected by this treatment. And so the advantage of this is that infection risks is really not magnified with this approach, because you still have some cells that are in the body that have not been affected by this treatment. On the other hand, you still have some cells in the body that still produce graft-versus-host disease. So the effects here have been milder than other systemic treatments in terms of controlling graft-versus-host disease. So if we talk a little bit about chronic graft-versus-host disease, There is really no time limit. This can develop at any point post-transplant, usually after 80 days. It requires some appropriate diagnostic criteria. So scleroderma or esophageal thickening or the Sicca syndrome, those are all characteristics of chronic graft versus host disease. Here you can see that peripheral blood stem cells cause higher rates of symptoms and chronic GVH manifestations in the different organ systems like skin, mouth, etc., when compared to bone marrow. And so these differences have been significant, and it caused briefly, when some of the studies were reported, it caused briefly the rethinking, should we be using peripheral blood stem cells if it causes more graft versus host disease? Should we go back to bone marrow? That never caught on, probably because it's so easy to get peripheral blood stem cells as opposed to bone marrow. But even this difference may be changed in the future as we use post-transplant cyclophosphamide, as I mentioned before. So this may become less of a difference in the future. Here's the skin manifestations of chronic graft versus host disease. You can see chronic skin ulcers here, joint contractures. You can see vitiligo, which is the white clearing of the skin. And a lot of the manifestations can be found in the mouth, where you see kind of a lichenoid lesion, and these are diagnostic usually of chronic graft versus host disease. Chronic graft versus host disease is similar to an autoimmune disease. It occurs in 30 to 60% of patients. The pathogenesis here is thought to be thymic damage. And in some cases, of course, where the thymic damage may be less, for example, in children or in other adults, this is one of the theories for why you can eventually come off immunosuppression in a allogeneic stem cell transplant. That is, the thymus can reprogram stem cells and T cells to be recognizing the recipient as self, as opposed to not self, and producing chronic GVH. This is not the case, of course, with kidney transplants, where you have lifelong immunosuppression, but the thymus, of course, because there is no functional way for the thymus to reprogram cells with a kidney transplant, kidney transplants have lifelong immunosuppression. So the treatment is, again, glucocorticoids, usually 1 milligram per kilogram per day, and then tapering gradually. Often requires at least 1 year of therapy. And 40% of people probably require therapy for at least 4 years. Ruxolitinib, ibrutinib, and there is a new compound called Resrock, which has been used to treat chronic graft versus host disease. We talked about extracorporeal photopheresis. And then to just summarize for graft versus host disease, we have acute and chronic, acute here on the left, chronic on the right. Classic acute graft versus host disease occurs sometime between 2 weeks and day 100 post-transplant, whereas classic chronic graft versus host disease can occur between 80 days and beyond. And then there are a couple of other categories. There's an overlap syndrome that you see there, which has elements of both. The symptoms here shown on either side. And you can have a late acute graft versus host disease, particularly in patients who have had cord blood transplants. You can see the symptom summary there for acute graft versus host disease. I won't recapitulate that. And on the right, chronic graft versus host disease. Infectious complications, there have been some good review articles out, which I've put, and incidentally, I've put review articles throughout the text. Some of these are pretty straightforward, and some of these we've eliminated now with treatment, with prophylaxis. So we've eliminated a lot of the bacterial infections, the herpes simplex infections, the fungal infections, with many of the new drugs that we have. But infection risk is still a problem. CMV infection is still an issue in some patients. Letermovir, over the last 5 or 6 years, has been employed to reduce the risk of developing CMV infections. Hepatic complications include largely sinusoidal obstruction syndrome, and this occurs in the first 2 to 3 weeks after transplant. The onset is usually somewhere between 3 and 6 days. So unlike graft versus host disease, it occurs much earlier, usually with sudden weight gain and then an elevated conjugated bilirubin, usually on day 6 or after. And it can be mild, moderate, or severe in its manifestations. Most people recover. Defibrotide is a drug that may be helpful in severe cases where there's multi-organ failure. Defibrotide is expensive and it's effective, but not a magic bullet by any stretch. There are a lot of risk factors for sinusoidal obstruction syndrome. I won't go through them all here. A lot of them make sense. Hepatitis, if you've had Mylotarg pre-transplant, that's a risk factor. Other things you can see here. As we think about how sinusoidal obstruction syndrome occurs, there are a number of things that can produce liver swelling and ascites, which are some of the signs of sinusoidal obstruction syndrome, along with a rise in the bilirubin. So this shows that, you know, if you have congestive heart failure, of course, you can have liver enlargement and sometimes ascites if it's severe. If you have Budd-Chiari syndrome, where you have clotting of the hepatic veins to the right atrium, you can have a back pressure into the liver that causes these symptoms. And then you have sinusoidal obstruction syndrome, which really affects the sinusoids and the central veins in the liver itself at a microscopic level. And so how does that occur? Well, here you see up on the left, you see the portal triad here, where portal blood comes in to the liver, percolates through the hepatic sinusoids, and then leaves the terminal hepatic vein, as you can see from the previous slide. That is, the liver then drains through the hepatic veins into the inferior vena cava. So what happens is the hepatic sinusoids have a sinusoidal layer of cells here called sinusoidal endothelial cells. And these are kind of loosely connected to the liver, to the hepatocytes in general. There's a small space here called the space of Dicey between these two. And what happens is these cells are sensitive, more sensitive to chemotherapy and radiation. And so when chemotherapy and radiation occur, having these cells perhaps previously damaged in the ways that we talked about previously for risk factors, these cells come loose and basically embolize downstream toward the hepatic vein. And this is what produces a backlog as blood continues to flow into the portal vein. So the portal vein swells. There's pressure on the bile duct, causing an elevation in the bilirubin, and you can see portal hypertension, swelling of the liver, and ascites. So in the severe cases, multi-organ failure, defibrotide seems to improve survival. Not sure why. We did not use heparin as a way of preventing the sometimes what we think might be secondary clotting in the hepatic venules. Dr. McDonald, who is probably the world's expert in GI issues related to transplant, did not believe in heparin, did not think there was evidence to support heparin. At City of Hope, I learned that City of Hope does use heparin in the very, very intense TBI-related ablative regimens. But so far, I would say there's no evidence broadly that heparin is useful. Defibrotide may be useful modestly in multi-organ failure problems. The pulmonary and cardiac complications are pretty straightforward. We're doing older patients, so patients have pre-existing coronary artery disease. We're also using high-dose cyclophosphamide, which could sometimes cause a myopericarditis. We have cumulative doses of doxorubin in some patients who've received prior therapy, pre-transplant. TBI and prior local radiation can affect the heart, depending upon where the radiation has been delivered. And in amyloidosis, we do autologous transplants for amyloidosis. And one has to be very careful of fluid balances and monitoring that while patients receive autologous transplant for amyloid because of the amyloid involvement of the heart. These are the pulmonary complications and their timelines. We're not going to go through all of those. We'll pick out a couple. The most significant ones are the idiopathic pulmonary syndrome that can occur, or a peri-engraftment syndrome. Rarely patients have pulmonary veno-occlusive disease. That's a very rare complication. Diffuse alveolar hemorrhage occurs in a few % of patients, but when it does so, it's pretty devastating. And then late complications that are often associated with chronic graft-versus-host disease include bronchiolitis obliterans and so forth. Diffuse alveolar hemorrhage occurs in about 5% of patients with either auto or allo, often depends on the conditioning regimen. And usually the onset is with shortness of breath, drop in the counts, diffuse infiltrates, and hemoptysis or hemorrhage on BAL, on your bronchoscopy. A lot of different risk factors for that. The treatment is high-dose steroids, 250 milligrams per kilogram, up to 2 grams of steroids, and of course, giving appropriate supportive therapy in terms of platelets. So diffuse alveolar hemorrhage is hemorrhage into the alveoli, as you see here, with diffuse changes on a chest CT. The CT pattern is somewhat characteristic. This is called crazy paving on the right, and on the left has that, perhaps that pattern, if you can kind of use your imagination and say that maybe it looks like that. Not a pathognomonic diagnostic presentation, but would suggest diffuse alveolar hemorrhage in the proper context. The key to the diagnosis of diffuse alveolar hemorrhage is when you do a bronchoscopy and you irrigate, you find that initially you may have a small amount of blood, but then as you continue to irrigate, the amount of blood increases in concentration, which is usually the opposite of what you find in someone without diffuse alveolar hemorrhage. It's usually the other direction. So bronchiolitis obliterans is a feature of chronic graft-versus-host disease. It usually occurs around 1 year. It's an obstructive airways disease and variably responds to steroids and other immunosuppressives like Jakafi and so forth. Cryptogenic organizing pneumonia is a less frequent form of pneumonia that responds to corticosteroids. It is largely a restrictive or reduction in diffusion capacity. Again, occurs later in transplant. The long-term complications in adults of transplant, of course, probably many of you can guess. Chronic graft-versus-host disease produces lots of different complications. Ultimately, ocular complications like cataracts, esophageal webs, which makes it difficult to swallow. We talked about bronchiolitis obliterans. Sometimes the drugs that we use, of course, cause chronic renal insufficiency, tacrolimus, sirolimus. Heart failure, iron overload, hypothyroidism is common in people that get radiation. And of course, very important is how people adjust to some of these chronic side effects. And of course, rarely secondary cancers can occur. And I should say that many of these complications go away with time and affect, of course, a minority of patients. So I want to emphasize that the positive effects of stem cell transplantation far outweigh the negative effects in most patients. if you look at long-term secondary cancers, you can see here that solid tumors produce the greatest number or associated with greatest number of in transplant patients. The incidence, though, is quite small. If you look at the incidence, it's 4% or less. And for MDS and AML, less than or equal to 1% of patients. Now, once you develop a secondary cancer, then your prognosis changes. So if you're one of the 1% of people post-transplant that develops MDS or AML, it's a pretty poor prognosis once that happens. On the other hand, if you develop a solid tumor, the prognosis is not great, but you can survive a solid tumor in some cases. So it emphasizes the importance of screening, continuing to screen for solid tumor malignancies in patients who are at risk. Overall, the late mortality of people who survive over 2 years is certainly not what it is for normal people, but it is substantial and would otherwise be much lower had one, in most cases, left the disease to be not treated by transplant. These are the non-relapse causes of death that you can see here. Secondary malignancies, SMN, as you can see, pulmonary, cardiac, and most importantly, chronic graft-versus-host disease. So happy to answer any questions. Sorry that went a little long, but happy to answer questions. Hopefully I didn't put anyone to sleep.
Thank you, Professor Stewart. Thank you for your comprehensive presentation. We have a couple of questions from our audience. First, from Professor Ashrafi from Isfahan University of Medical Sciences. She has posed this following question regarding haplotransplants. When post-transplant cyclophosphamide is utilized, does graft manipulation play a role? And is T-cell depletion of the graft employed as a preventive measure against GvHD in this setting?
Yeah, no, usually the post-transplant Cytoxan doesn't require any additional graft manipulation, either T-cell depletion or other forms of graft manipulation. What we think it does is it's a strong form of moderating T-cell reactivity, that by itself. And so other manipulations are not needed. If you T-cell deplete grafts, as we used to do in the old days, we would have higher rates of graft rejection and higher rates of relapse. That is, you'd eliminate that graft versus tumor effect. With post-transplant Cytoxan, it doesn't appear to affect the relapse rate, and it seems to be associated with a reduction in graft versus host disease, particularly chronic graft versus host disease. So probably doesn't eliminate all of the T cells like we would with T-cell depletion, but rather moderates the T-cell reactivity. You can, I should say, because we give post-transplant Cytoxan on days 3 and 4 after the transplant, there's not much given in the day 0 to day 3 time period, where you can get a cytokine release syndrome. And sometimes that has to be treated with tocilizumab in that intervening period before the Cytoxan actually comes in and does definitively treat that. I haven't mentioned that, but that is something to think about with haplotransplants, is you can get some cytokine release syndrome symptoms.
Thank you. And the next question from Dr. Dunyagard from Armenia. She asked about the recent studies indicate that the gut microbiota is instrumental in influencing post-transplant outcomes. Has Are there any specific strategies or intervention under investigation to optimize the gut microbiota composition both before and after transplantation, with the aim of improving success rate and minimizing complication for transplant patients?
Yeah, great question and very relevant. I think we're still learning about how to do that, how to change the microbiome to make it relevant for reducing graft versus host disease and other complications, particularly as it affects the gut. Yeah, I mean, there are studies ongoing that would suggest that different microbiomes may predispose to different degrees of graft versus host disease. We just recruited Dr. Marcel Vandenbrink from Memorial Sloan Kettering. That's one of his areas of major research. He's going to be the new president here at City of Hope. And he will bring a whole group of people looking at microbiome and its effects in transplant. Right now, there is not a lot of definitive applications of that. You know, I'm old enough that I go back to my early training in transplant at Memorial Sloan Kettering for a number of months. There was a fellow there named Richard O'Reilly who was very interested in this. And his theory back then was that maybe what we ought to do is give all the patients sterilizing oral antibiotics, kind of like we do sometimes with Clostridium difficile. We give oral vancomycin. But he gave vancomycin, gentamicin, other antibiotics to try to completely sterilize the gut. And then his theory was perhaps we should populate the gut after transplant with microbiome derived from donor gut. So in other words, you culture the gut of donors who you used for the transplant, and maybe there would be less reactivity because the donors were used immunologically to that gut flora. That didn't really pan out. They weren't able to show that it made a difference, but that concept of microbiome being important has been resurrected. So it's a great question, but we don't really have any definitive approach yet to how we use those differences.
Thank you for your answer. And the next question by Dr. Rezai. He wants to know, as far as I know, you mentioned different options about the long GVHD. He wants to know about overall, when treating GVHD, at what point we consider second-line treatment following corticosteroid therapy? When is the proper time to decide that we don't have the proper response and we should switch to the second line?
Yeah, great question. Usually we see responses for acute graft versus host disease within a few days, sometimes even sooner. And you know, as you begin to see improvement, let's say a fading of the skin rash, a reduction in diarrhea, you can begin to consider tapering the steroids, you know, usually maybe 10% over every 5 days, something like that. You don't taper until you begin to see a good response. At the point of being out 10 days to maybe 14 days, if you've not seen a response by that time, then it's appropriate to begin to use a drug like Jakafi. So it does take at least a week of trial at the conventional steroid dose before you begin to think of adding alternative therapies. As you add alternative therapies like Jakafi, it is of course important to begin to taper the steroids because people can't withstand long-term high-dose steroids, so you need to begin to taper steroids also, you have to taper them slowly. Resistant graft versus host disease, as I mentioned, is a poor prognostic sign. Probably if you have someone who is very slow to respond, let's say you have someone who produces a couple liters of diarrhea and then with steroids produces a liter of diarrhea but still has a lot of diarrhea, you may want to add then Jakafi earlier rather than later as an example. So a lot of it is dependent upon the degree of response or lack of response. Getting started on treatment with graft versus host disease therapy is important to do it as quickly as you can. It also is important to make sure you have the right diagnosis, as I mentioned, right? So if you have moderate diarrhea post-transplant or even mild diarrhea, it's important to get endoscopy. It's important to look for CMV and other enteroviruses. For skin rashes, it's important to think about, if you can, other complicating things like drug rashes where you really wouldn't use steroids. So a lot relates to clinical judgment. I don't know if that helped.
Okay, thank you. The next question by Dr. Irfan. He wants to know about your recommendation about the pulmonary chronic GVHD, as you mentioned, for about the different choices. He wants to know if the extracorporeal photopheresis is not available, and his patient is a 19 years old and resistant to corticosteroid switch to the ruxolitinib, which also was not responsive properly. He wants to know about your recommendation about the next step if you don't want to help.
Yeah, it's a good question. You know, when you get down to second and third line or fourth line therapy, it's really hard to say what the right approach is. There is a compound called Resrock that's out that people are using more now. Ibrutinib has been used, but the success after third, fourth, fifth line therapy is really tough. But those are two alternatives that you can use beyond steroids and drugs like Jakafi. Jakafi we think about more for acute graft versus host disease than chronic. Is the graft versus host disease largely confined to the skin, or is it involving other areas, I guess would be my question.
Thank you. Would you please, I want to ask the...
Yeah, I was just going to ask that question, is if you have skin GVH as the predominant feature, sometimes you can use ultraviolet light. So not extracorporeal photopheresis, but actually ultraviolet light, like PUVA therapy, which sometimes can help with skin involvement. It doesn't do much systemically, but can help with the skin issues.
Thank you, Professor. Would you please, I want to ask to give the microphone to Professor Haj Fatali for his question to pose.
Thank you, Doctor. Do you have my voice?
I
Yes,
do.
we hear you.
Thank you, Professor.
It's very melodious.
Thank you.
It sounds good.
Regarding to the first question, I want to ask you indeed, I need your advice. You know, in Iran, the rate of CMV infection is very, very high. And when the GVHD occurs, and especially when it's combined with CMV infection, you know, the handling of this disease is very difficult for us, first, especially when we have also shortage of medication. So the most important thing for us is to prevent the GVHD, okay? So in haploidentical, as you mentioned, when we use, okay, post-transplant endoxa, but what about my colleague, Dr. Ashrafi, asked you whether we can do also T depletion or not. It is correct that when we use T depletion, the rate of GVL is very high, and you mentioned it's correct. But if we reduce the number of T3 cells, okay, to less than 100 or T deplete, let me say somehow, and after that, after a while, we add back the cells. We add back these cells for the effect of GBL. What you say about this way of treatment?
Yeah, no, I think it's a very interesting approach. People have, tried to titrate the amount of T cells that you can add back after taking them out as a way of moderating graft versus host disease and improving immune function. There's actually a study going on at the Hutch where there is modification of T cells and adding them back, which so far has actually been pretty successful. It's not an approach that is, available at this point, but I think you're along the right tracks for doing that. What has been your experience so far for that?
We have some experiences. We just now actually do for all of our patients with haplotransplantation indeed, especially when who are are very high, in risk of GVHD, in high risk.
Yeah. You mentioned CMV before. How do you prevent CMV? Are you able to do early institution of drugs like ganciclovir? Are you able to analyze CMV using PCR technology? How do you?
Yes, we have all of these. Yes, we have all of these.
Yeah.
But usually occurs CMV infection, indeed. And no, when the CMV infection occurs, no, we do not have enough medication indeed.
Yeah. So the other thing to think about too is there are, going to be maybe half the population that is, at least in our country, that's CMV negative serologically at the time that they present with a diagnosis of, for example, acute leukemia or other malignant disease. Keeping those people CMV negative should be a goal long before they get to a transplant. So if you can identify them up front and as you support them, give them products where the white cells are filtered. The white cells, as you know, contain latent CMV in some cases. So if you can give them blood transfusions or platelet transfusions that have been filtered for white cells, that will protect them from developing CMV. And then, of course, if you can find a CMV negative donor, that also is a good way to prevent CMV. But once you've been exposed to blood products that contain CMV, that is, those that may not have been filtered in terms of white cells, then you have someone who has latent CMV and is at risk for developing CMV disease if they undergo a transplant. So that's one of the board questions that we asked. I'm happy to, by the way, to send you some of the board questions that I put together. I can send that to Marjan. But one of the cases that I presented in that board question was someone with AML.
TUMS.
Pardon me?
Sorry.
Oh, yeah, one of the questions was a young fellow who had AML in second remission, was scheduled to do an allogeneic transplant. In the beginning, he was CMV negative, but because he was treated in a rural area where attention was not paid to giving products that were white cell filtered, he acquired CMV, and he acquired CMV right at the time he was scheduled to undergo a transplant. So it was probably something that could have been prevented. His donor was CMV negative, but he turned CMV positive right before his transplant. Could have been prevented had he gotten CMV filtered blood products during those induction treatments that he had. Just as an additional point of education, if you do have an active CMV infection, that is, the PCR is increasing for CMV, the mortality rate is pretty significant. And in this question, the issue was, should you proceed with the transplant or should you delay it? And the answer is, as long as he's in remission, you can delay for a couple of weeks and treat him before he undergoes transplant. So for example, we always look for CMV PCR right before we start conditioning to make sure that there's no active CMV infection, because the mortality rate is very high if you have an active CMV infection during transplant. So I gave you a lot of information there that you didn't ask for.
Thank you, Professor. Thank you, Professor Hashvatali, and also Professor Stuart. I want to add
Can I have second question?
Sure. And also, I want to add another note about our patients according to our recent research in Shariati Hospital. We had almost about 100% of CMV positivity in our patients. Even also donors and patients both are CMV positives. Only one patient in about 130 transplantations, and maybe it's the better choice to screen the CMV before doing the transplant is the best option to cure the CMV and to treat the CMV before the conditioning. Yes, please, Professor Hashvatali, and I should ask another couple of end question to also have Dr. Aghabeghi to present two cases with this slide if we will have time, Professor Stuart.
Oh, okay. Would you like me to stop sharing?
Okay.
Or did I stop sharing? Oh, okay. Good.
Professor Hashvatali, thank you. Would you please pose your question? Thank you.
Dr. Rashidi, I still cannot upload my slides over here.
Okay. Professor Hashvatali, can you say your question
here.
now?
Yeah, I will stop sharing. Let's see. How do I do that? Let's see.
On the top, you have the option to stop sharing.
Aloma, thank you.
There we go.
Can I ask?
Sure.
Okay.
Thank you.
Yes. Sure,
nice to see you.
Thank you, Professor Stuart, and thank you, Dr. Rashidi. Our experience about the use of Jakavi when the GVHD is resistant is not good indeed. Why? The rate of GVHD indeed is decreased, but unfortunately, the rate of infection getting high and high. Our patients do not die from GVHD, but die from infection. And the result is the same. But what about the use of cell therapy in these patients? Do you have any experience? We do DSC, if you know, and we have good result indeed.
When the use of I'm sorry, the use of
DSC, decidual cell mesenchyme.
Okay. You said decidual cell?
Yes.
The stem cells derived from the placenta, you mean? Yes.
Oh, you mean cord blood?
Not cord blood, from maternal part of the
Are you talking about mesenchymal cells?
Yes.
Okay.
No mesenchymal cells. No. Decidual cells, Professor.
Okay.
Decidual cells.
Well, you'll have to educate me about that. Tell me about it.
So, you know, we have the experience of DSC. These DSC cells, these are cells from maternal part of the, umbilical cord, and these are some, as you know, these are very good cells to stop the inflammatory process. We have the experience of these cells more than 5 years, and are very, very good. And also, of course, exosome cells, and the use of exosome for prevention of GVHD and also the treatment of the GVHD.
Actually, decidual from placenta is mix of mesenchymal and embryonic stem cells. There, I suppose there is no specific term for the decidual. Professor Ashby, do you mean the embryonic and mesenchymal derived from the placenta?
Not mesenchymal. Mesenchymal is mesenchymal, but these are some decidual cells, as you said.
Yeah. Well, if you could, do you have, are any of your results published that you could share with me? I'd be happy
Yes.
to.
Can I send you after this presentation
absolutely.
to your email?
That'd be great. Thank you.
Okay, thank you.
And then the next question before the presentation of Dr. Begid, asked from Dr. Peker from Isfahan University also. He wants to ask about is there a role for lenalidomide administration in cases of primary disease relapse and GVHD, especially when reducing immunosuppression?
Yeah, we have used lenalidomide earlier for things like graft versus host disease, but probably using it much less so now. It's not at City of Hope and at the Fred Hutch, we don't really use it much now for GVH.
Yes, thank you. And the final question by Dr. Mohan, he wants to give about the precision medicine. Given the advancement in precision medicine, are there current trials investigating the influence of genetic and epigenetic profiling on donor-recipient compatibility, aiming to enhance engraftment and long-term outcomes in hematopoietic stem cell patients?
Yeah, it's a good question. I'm sure there are people looking at that. I have not seen anything definitive in terms of bringing that forward for practice, other than, people are looking at other characteristics of donors other than just the molecular matching. As I mentioned, they're looking at not only is someone molecularly matched or mismatched, but what's the expression of those antigens. So I think all of those things are eventually going to play a role in donor selection. I think the interesting thing is that we've kind of almost maximized, it would seem, our ability to get good matched donors. If you compare us to the HLA sibling donors, right? I mean, you could see in AML, it was pretty close. Less so in other diseases, so there are probably opportunities there to improve our matching. But I think those are great questions, and those are great areas for future research.
Okay. Dr. Aghabegi, would you please share your slide with the case presentation? And by the way, I referred Dr. Mohan to a recent publication by Blood Journal in September 2023 about the novel developments in prophylaxis and treatment of acute GVHD. It's published recently, and it's comprehensive journal by Dr. Jamie, I suppose, about the novel approaches in
Mhm.
GVHD. Dr. Agbegi, can you share? Or
Yes.
okay,
Unfortunately, I can't share it. I've got a new MacBook Pro, and
you
it
can
seems that I cannot
if
really
it's
share it with
possible,
you.
you can
Maybe I
read
can
it.
read it. Yes,
Yes,
exactly.
okay.
In the name of God, the most compassionate, the most merciful, first of all, I want to really thank Professor Marcus Swart for his great lecture, as always, about bone marrow transplantation. We are really so glad to have him in the past 2 years here. And the questions I just want to ask you before I got into my cases is that, do you have any experience with the new ROCK inhibitors like blemusodil? I don't know the exact pronunciation of it, but it said that maybe it's the second one, the second drug that is FDA approved for chronic GVHD, and
Resrock.
the overall response rate is about 77%. Do you have any experience with this new drug?
Yes, we have. We have. Our response rates are probably not quite as good as 70%, but we think it's a promising drug. Absolutely.
Yes.
And yeah, and
And it, yes.
you're talking about Resrock.
Yes, exactly.
Yeah, absolutely.
And about the other things that you have told us about FMT, it seems that many studies are all around the world, especially one in Minnesota, that they are doing it as a prophylactic thing for GVHD. I think the one that has been discussed in MSK in the past 2 or 3 months ago in the third symposium of the toxicities of transplantation and things like that. I've just heard one of the presentation that was presented by Dr. Armin Rashidi, I think from the University of Minnesota. And I think that they are using it as prophylactic matters, yes?
Yes, that's correct.
Okay,
So
thank you.
we'll see how that works. But thank you for your
Exactly.
comments.
Thank you. Thanks a lot. Excuse me that I really cannot share my slide with you. I've got this new MacBook Pro and I cannot, I don't know how to share them with you.
Okay.
The first case is these cases that I want to tell you are real cases that we have encountered in the past 2 weeks. The first case is a 40-year-old woman. A 40-year-old man, he was suspected of having ITP at age 12. In that time, his platelet count was 10,000. His hemoglobin was 14, and his white BC was 5,000. He did not respond to glucocorticoids in that time. He's now 40 years old, and in that time, he was 12 years old. He went under splenectomy in that time, and he did not have any more problems from that time. And until 6 months ago, he developed pancytopenia. His platelet counts became 10,000, white BC 6,000, white BC 4,000, and hemoglobin 8. In PBS, what we thought was local erythroblastic features. Bone marrow aspiration and biopsy has been done for this patient. It was a hypocellular marrow with overt fibrosis grade 3, and it was highly suspected for primary myelofibrosis. We have checked his blood for JAK2 mutation, MPL mutation, and COL mutation. They were all negative, and the peripheral blood blast count was about 2%. What we have done for this patient is that we have started ruxolitinib first for his problem, but because of his low platelet count, his platelet count get lower, and we did not have any access to pacritinib or momelotinib in our country, so we had to stop ruxolitinib, and he started having packed RBC transfusion once a week and platelet transfusion also once a week. So for this patient, our final diagnosis was primary myelofibrosis, and because of the driver mutation, all driver mutations were negative. I mean, COL, JAK2, and MPL. It was a triple negative patient, and his prognosis was so poor, and what we have done is that we have used DIPSS plus scoring. His scoring was about 5, and as we know, his median survival is about 16 months. So we have started to search for donors for him. He only has one brother, which was about 30 years old, but the problem was that he had multiple sclerosis. He also has a haploidentical father who is 70 years old. We have searched the bank for donors. We have found 5 fixed donors in Iran and 6 fixed donors in the US. The question for this patient is that he only has a haploidentical donor, which is father, and another one is a full match donor in the US and mismatched donors in Iran. And the problem is that for applying the full match donors in the US, it takes time and it takes almost a lot of money. So the question for this patient is that although his father says that we can pay for the money that we should pay for this problem, but the problem is that which donor? My question is that which donor is the best for this situation? And in the next part, which regimen we should use, myeloablative conditioning, reduced intensity conditioning, and how would be the outcome of this patient?
Yeah, so he has a fully matched donor in the United States. Is that what you said?
Yes, exactly.
Yeah, and the haplodonor has multiple sclerosis. I assume he has no children. Is that correct?
No, yes, he does not have any children. His brother has multiple sclerosis, and his father, who is 70 years old, is haploidentical with him.
Yeah. Well, that's a tough one. You know, obviously the best approach is to get that United States donor, right? If there's any way to do that, that would be the optimal donor. We would probably use a myeloablative approach. What did you say the degree of myelofibrosis was?
It was 3 out of 3.
3, okay.
Yes.
Yeah, we would probably use a myeloablative approach, use that unrelated donor. That would be the optimal thing. The question then is, what would be the next optimal approach?
Yes.
You know, it would be interesting to do a little bit of a literature search and see if there has ever been a case of multiple sclerosis transmitted through a transplant. You know, we've had people who have diseases that are not detected when they're donors. In other words, there have been cases where you've traded multiple myeloma for leukemia because the donor had subclinical multiple myeloma, right?
Yes.
That's a devastating thing. It would be very interesting to know if multiple sclerosis fit into that category as well. You could never be reassured, of course, that you wouldn't transmit multiple sclerosis. I think it would be very risky to do that. Do we know how prominent the multiple sclerosis is in his brother? Is it highly clinically?
Yes, it's highly clinically prominent, and he could not do anything for his routine life, and he cannot just walk, and his performance status is really so low.
Yeah, so that would probably exclude him as a donor, I think. Again, be interesting to do a literature search and see if anyone has inadvertently used a multiple sclerosis donor. Probably not, but then you're kind of left with a dad.
Yes.
And post-transplant cytoxin. And so I think it would be a high-risk transplant, but
yes,
I think that's probably your only option if you can't get that U.S. donor. If you can get the U.S. donor, that'd be
the best option.
Yeah.
Yes, and use according to the 2023 New England publication, use TAC microphenolate post-transplant cyclophosphamide. Yes.
Correct.
Exactly. Thank you. The next case is Of course, in Shariati BMC Center, there are clinical trials that they are doing autologous stem cell transplantation for multiple sclerosis. And we should just see the results. We still don't know the results, but we are using a lot of autologous stem cell transplants as a reference center for many of the multiple sclerosis patients over here. The second case we want to discuss is a 30-year-old woman. She has presented to his primary clinical care physician because of malaise and weakness. In the physical exam, she did not have any kind of lymphadenopathy or splenomegaly. Her CBC, in the CBC that has been performed, what white BC was 10,000, her hemoglobin was 10, and platelet count was 50,000. Bone marrow aspiration has been done for this patient. It had the L3 morphology, and it had abnormal mature B cells, 30% of the bone marrow. It was CD10 positive, CD20 positive, CD5 negative, TDT negative, CD34 negative, and CD117 negative. And it was highly suggestive of Burkitt lymphoma for this patient. Cytogenetic study has been done for this patient. It was referred to our Center for Bone Marrow Transplant. Cytogenetic study has been done, and it had translocation of 814. And the CT scan has been done for the patient in another center, and she did not have any kind of lymphadenopathy. So the final diagnosis for these patients, although it's not really that much common, is Burkitt leukemia. And her physician started treating her with hyper-CVAD, not orthodox M or RI-VAC, or not those adjusted R-epoch, and she has not been given rituximab with hyper-CVAD. Only hyper-CVAD has been given to her, and now she's in complete remission. And she has a full match sibling, and she has come to our center in order to ask us that, should I transplant? I got hyper-CVAD. I did not get rituximab. You know, it's not a real, she did not she has not been treated in a real standard way. Her CSF was not involved, and her performance status is really good. And we all know that for Burkitt lymphoma, we really do not recommend bone marrow transplantation in the first CR. But for this situation, for these patients, what is your recommendation?
Yeah, I would agree. I think as long as she is in remission, I agree. We would not recommend bone marrow transplant, blood or marrow transplantation for this patient at this particular time. Hopefully she'll be cured. How far out is she?
She has finished hyper-CVAD regimen, and it is 6 months after that time that she has come to our center. And she's really good, but we were just thinking that you know, that there are really some questions about this patient. We did not really see that much patients with Burkitt leukemia, just Burkitt leukemia. We usually see patients who have Burkitt lymphoma / leukemia, sure, and bone marrow involvement. But in this particular patient, she has only bone marrow involvement, not any other parts of the body.
Yeah.
Yes. It's a rare
case. No, it sounds like you've done a great job. Does her marrow look normal now?
We did not perform bone marrow aspiration biopsy in our center, but his doctor performed bone marrow aspiration biopsy, and according to the flow cytometry, it is now, yes, it's in remission.
Yeah, I think if you have flow cytometry remission, the bone marrow looks normal, the cytogenetics are normal, I probably wouldn't, I'd think hope for the cure.
So you recommend that we should do cytogenetic once again for this patient, yes?
Yeah, I would make sure that she's in remission. Absolutely.
Okay.
Is she's completely done with hyper-CVAD? Is she done with all courses?
Yes,
okay.
Exactly.
Yeah. Good.
Thanks a lot for your great recommendation and suggestions.
Thank you, Professor
Thank you,
Stuart.
Dr. Rashid.
May I have the final question, if there is any, if you have time, or you may close the webinar? Okay, thank you. Actually, it's a case, but I want to know it as a question. What are your primary consideration for a patient with lymphoma and HIV infection who is going autologous transplantation? Especially, are there any concerns regarding the viral load at the time of stem cell collection?
Yeah, I think you want to reduce the viral load as much as you can. That would be really important. I think it's still experimental as to whether or not the patient will benefit from that. If you have that special donor which is HIV resistant, that's a big win, but that's pretty rare. So,
Yes. Especially in
have you done a search for that?
Actually, we referred her to, because it was my patient, and I want to send her for the consult to the Charité Hospital. And she's waiting for the consult, but I want to know about actually the lymphoma is the T-cell lymphoma, peripheral T-cell lymphoma, and she has also suffered from the Kaposi sarcoma also. They're diagnosed together, but when I treated the T-cell lymphoma by CHOEP14, because of his age is about 34, also the Kaposi was regressed with the treatment. She was also at the diagnosed in the leukemic phase. The peripheral blood flow cytometry was also positive for the T cells. And I want, actually, I haven't decided for the type of transplantation. I wanted to know if she has had the proper donor for the allogenic transplantation or the autologous transplantation. Which of them would be the best option?
I think it's a pretty tough case. I'm not sure an autologous transplant will help her much. She has peripheral blood involvement. She presumably still has HIV, viral load. I think you've implied that. And she has Kaposi sarcoma. So I think it would be, don't know that autologous transplant is going to help her, unfortunately. And unless you can get a good allogeneic, that rare allogeneic transplant, which I'm not sure what the role of Kaposi sarcoma would be there, and whether or not that would be improved. I would hope it would be. I would, if I had that rare donor, I would probably still try it.
Yeah, she has got, as far as I know, she's got a sister matched in the low resolution HLA.
Yeah.
Also is with no children. Maybe would be a full match donor.
Yeah, I don't think I would use that, just given the HIV issue. HIV sounds like has been a very prominent part of the problem she has. Is that correct?
Okay.
And unless you have that special donor, I don't think it's gonna help. Okay.
So you would suggest allogenic stem cell transplantation, or you're just treating the no transplantation?
Yeah, I think that's what I would suggest, unless you have that special donor that's HIV resistant.
Okay, thank you. I would like to close this webinar, and thank you, Professor Stuart, for joining us early in the morning and delivering such a comprehensive presentation on hematopoietic stem cell transplantation. Your insights and vast experience in this field have truly enriched this webinar. I'd like to extend my gratitude to all the audience attendees, especially those who participated actively in this webinar. And lastly, I want to special thanks to Dr. Wazi for entrusting me with this moderating opportunity. Thank you all for attendees, and stay safe and take care.
Thank you very much. Thanks for the
Thank you.
opportunity to come. I really enjoyed the discussion. So
Thank you very much. Thank you.
Yeah.
Thank you, Professor Swart. Thank you, Dr. Rashid.
thank you.
Thank you. Thank you, Professor Ashfatari, Dr. Aghavegi. Thank you.
Thank you.